Okay, I wanted to talk about improving relationships in psychosis, and this is primarily about improving relationships. Is this going to turn up? Wait a moment. Oh yes, there we are. Improving me giving this talk smoothly relies on me being able to see over there, which is may not be. My glasses may not be up to it. We'll see how it goes. The picture there is by Annie Ray, who was a service user who was also an artist, of course, and Paul Bevington and I wrote the book, Living Mental Illness, and we asked her to contribute to that, which she very kindly did, and I do think it's a very nice picture and gives some sense of what people are beginning to deal with. I've got to do this hard, haven't I? Oh, God. I wanted to cover today, or I thought I would cover today, and I'll make sure I'm not go on too long, really the research findings. There's a bit of background, which I don't really need to spend any time on because people in the room know all too much about caring relationships. I wanted to talk about the research findings over the years and where that's got to and update you on that perhaps. A little bit about the models that we've developed from that in terms of what's happening, what we understand and where that leads, and what it means for the kind of interventions particularly for carers themselves. And this has taken a long time to get to this stage. How do you actually help yourselves, carers, to in this journey of recovery? I very much like that phrase. It's rather sort of slow, yes. So the Schizophrenia Commission said 11.8 billion a year that caring costs. I mean, who knows, it's a very large number. And we have identified, we think, in England that there's 220,000 people living and actively caring for someone with psychosis. It's very hard to get these numbers. We've done lots of demographics. It's something like that, and we've been trying to contact them. And as you well know, this is just a discussion about what it's like to have psychosis. I do think it does help to write things down, as Patrick was talking about. There is something about diary writing which is quite helpful anyway for processing things. And this is just a quote from the NICE guidelines of 2009. I chaired both the 2009 NICE guidelines for schizophrenia and the 2014 psychosis and schizophrenia guidelines. And this was one of the service users on the committee, on the guideline group, who just talked about what it was like to have be diagnosed in his mid-20s and how it started. And I was hearing voices, reading strange meanings into what was going on around me. This is a picture, David Marsh's Mercury, from it's called Schizophrenic Artists, Paintings Out of This World. And again, I just wanted to emphasize, as Patrick has done, and perhaps all of you do, that people with these diagnoses, they have other lives, they're jolly good at all sorts of things, and it's important not to just focus on the problems that people have, but also focus on their attributes. What's it like to be a carer? I'm sure you know all about this. I was just looking at the definitions. You're a carer if you provide help and support to someone with a mental health problem and or a physical disability. That's mine's definition. And one of the important things is the mutual part about that. And distinguishing what I'm talking about here are unpaid carers. We're not talking about professional care relationships here. We're talking about what it's like to find yourself in this position. This again was someone who was a husband of someone on the NICE guidelines, who I met subsequently and thanked him for his contribution to the guidelines, who again talked, I mean this is not recent, but it's still sometimes it's people's experience that someone who was diagnosed 20 years ago and we got married, and of course he didn't quite know what was going to happen next. We'd been married 4 years. I hadn't realized how serious things had become. And she was initially treated for depression because it's much more acceptable to talk about depression than to talk about more serious mental illnesses. And he was just talking about how difficult it was, the shock and the disbelief. And I had no accurate idea of what it was, what I thought it would blow over. And of course everybody would think that at the beginning. And my life would be all right again. Oh, that seems to be going backwards. That wasn't me. Sorry about this. That's going backwards. No? Oh, you want me to go that way? All right, let's try that. Sorry. Let's try that. This isn't entirely responsive, this. Okay, these are some quotes. They both happen to be 19-year-old parents. What upsets me most is that I'll never know what he would have been like if this illness had never happened. This was a first episode carer from one of our studies. And I found myself asking for God to take it from her and give it to me. Of course, if I could do anything to take it from her, I would prefer that. It's important never to underestimate the impact, as we've heard, that these problems have. And it doesn't necessarily get better over time. People can feel really that it's just never-ending. You get paranoid sometimes. You can't just dismiss it. Why can't you just sort it out? The relapse has been a huge blow to me personally. You think everything is better, and then bang, back to square one. We won't feel any better until we find a cure. And of course, there isn't a cure. There's managing these things. So it's serious issues about how you manage these things for yourself as well. So I've argued for years that families are a resource, not to be exploited, but are available, are very often still in the picture. It depends where you live. In central London, in inner London, where I did a lot of my work, there were not so many families, but there are lots of places where there's plenty of families, and I'm sure there's plenty of family support here, that people do remain in contact with families, and often it's very hidden, as we've heard. And of course, if you do that, that's emphasising normal community links, and a very important point about psychosis and about schizophrenia is that you lose your social network once you get these problems. If you have a diagnosis of schizophrenia, your network goes down to about 3. And this is why lots of people don't know about it, because you just lose contact with your friends. As we were hearing with Patrick, what do you say to your friend in the street? Do you really say, I've been in a mental hospital the last 5 years, how are you? It's really hard to discuss what's happening. And so you will have known people at school or in work or all sorts of places who you don't see anymore, and they've disappeared. And so one of the things that families can do, or people who are involved in care, is provide that hugely important social contact, because otherwise you get social isolation. And of course, at its best, if things are going well, it's a really, really helpful environment in which to recover. Sorry, I'm not very smooth on this, am I? We know from all the research, and this research has been going on since about the 1950s, and people keep on finding out the same thing. It's rather tedious, I feel. But I'm trying to update it here. There's a huge impact on the carers themselves of finding yourself transported into this role. It's associated with increased levels of stress and distress, and when you ask simple questions about clinical diagnoses for carers, they are about 40% of them will have a diagnosis of depression. I'm not saying that that makes you mad, it's just that it's depressing, it's very hard work, it's a strain, and it's difficult, and this is very under-recognised. There's also, when you use the same questionnaires as you would with anybody else, you find that 44% have trauma symptoms, have felt traumatised, often by the early stages, by the sectioning process, by the impact of going into wards and all sorts of things, that it's actually quite a traumatic process itself, and again, not to be underestimated. And that's a half meet criteria for PTSD. So there's a lot of unrecognised trauma for being in the caring role. And I think over the years it's become clearer that it's a bereavement. You're actually having something like a grief process to go through, although the person is usually not died, although often that can happen too, of course. But you're actually having to manage someone who has changed, and you're having to manage how you feel about that. And that's taken a long time to sort out, but when you think about it, that's obviously what it is. And we've just started, Juliana on with Mary, and one of my colleagues, we've just started to look at the violence in family settings for carers, and that's again a very, very tricky thing to ask about, very tricky thing to find about, but there is 52% of people reported patient-initiated violence over the years, and it's an important point that services don't just skate over that. I've been in team meetings when a wife had been punched. Oh, well, she was probably just annoying him, wasn't she? I mean, it's just rubbish that people don't take it very seriously, that these things, particularly in acute stages, can be dangerous. No? Yes? No? This is an illustration of the impact of care, as good as I could manage, and one of the reasons I share it with you, it's an Australian artist talking about Sunday evening, a woman with small children looking a little the worse for wear, and the reason I show it is that my sister-in-law sent it to me after I just had my third child, obviously, and she'd been visiting. I obviously wasn't looking my best, so I just thought it was one of the ways of talking about these things. So there's a consistent finding that carers have to cope with the heavy impact of care, that their distress is higher than that of the general public. We know that. And we've just done a very interesting study on using national survey data with Lindsay Smith, showing that there's a dose relationship, i.e. that more than 10 hours a week of caring and you're immediately shot into having these effects. You don't actually need to be doing that much caring in a week before you are starting to feel the strain and distress. And again, that's very underestimated. This is all carers, but particularly for mental health conditions, you're more likely to feel the kind of strain and the upset of it. The other issue that I've been involved in for a long time are relationship issues, which I expect people know about, that unfortunately it's always the negatives. We're all designed to pick up negatives, marvellous, isn't it? And that negative relationships in particular are much more likely to be related to subsequent poor outcomes in people with psychosis. And that family reactions are absolutely key, even when people are staying on medication, that there are things that families can do that will make a difference. And in particular, this comes out a little bit later, but there's quite a lot of evidence, some evidence, that warmth on its own relates to better outcomes. And that's what you're trying to do with your interventions with family work, is to try and get a warm family atmosphere back after the shock and the denial and the worry and everything, trying to get people functioning in a more normal way together and liking each other's company. Oh, I can't read that. Can you read that? I just had some examples, the kind of things that we're rating when we're talking about criticism and over-involvement. And that's not to say that these things are unusual or surprising. They're just indicators of a poor relationship. And you hear it on the radio when people are talking to each other about all sorts of things. And you also, the last one is talking about staff. He just goes on and on. It's irritating. He knows how to do it, but he doesn't do it. It's not just relatives. It's people who are in close relationships trying to offer help. It can easily get quite difficult to stay calm and be positive and to manage things. And we have known for a long time that those kind of relationships where things are not going so well are going to make recovery more difficult for both sides. And it interacts, one of the reasons it's a problem is because it interacts with how difficult the caring is. If you're finding the relationship difficult, you will also find the burden of care, what's called the burden of care, the impact of care. You will find that it'll be more difficult to do, obviously, because if you're not getting on very well with someone, and this isn't just in psychosis, you find difficult relationships in anorexia, in dementia, and all sorts of things. If you're having trouble, if you don't really like the person anymore, offering the care is much more difficult. And it's related in carers themselves to their own stress, low self-esteem, and a very interesting point is this what we've called avoidant coping, which again is very reasonable to have, to kind of, oh, well, I'll sort of just wait for it to get better on its own. And you get this even at first episodes. But of course, in something which is long-term, waiting for it to get better on its own is not going to work, and waiting for things just to get back to normal isn't going to be helpful. So that was a very important point that Patrick was making, that talking to other people about it, being open about it, trying to get support for yourself, it's absolutely crucial. And it's also, the other thing we've looked at are people's understanding of why these things are happening and what the reasons are that someone is both having problems or having particular symptom profiles. Why are they behaving like this? What's going on about it? And one of the things that criticism is related to is thinking that the person could do more themselves. If only they did more themselves, if only they could pick themselves up and sort it out, then things would be better. And trying to make them better by kind of pushing them quite hard to do things. Now, of course, you do want to push people, but you've got to get the right balance. And what you find with a more tolerant atmosphere that works a bit better is to kind of slightly be over positive, trying to find the positives wherever you can so that they are the thing that are being emphasized rather than being focused on the negatives. And because the way you understand what's happening is really important for outcomes again. Yes, okay. Another thing we've looked at, I've tried to kind of normalize this over the years, trying to look and use the kind of things that are looked at in all sorts of illnesses and look at them in psychoses and see how it relates, because psychosis has been very marginalized and, you know, this isn't the same, it's a different condition. Actually, it's about dealing with long-term problems sometimes. And what you find is that illness perceptions, one of my colleagues said this, accounts for most of the variance of outcomes. What you understand if you get a cancer diagnosis or you have a kidney disease or you have a heart attack, what you understand and what you do about it, that crucially affects your outcome. So if you think I've had a heart attack but I don't need to change my lifestyle or eat any differently or do any more exercise, that's not such a good outcome if you kind of take it on board and understand what the problems are going to be and what you're going to need to do about it. And you find in very similar reactions in psychosis that people who felt that the illness wasn't under their control, which of course it may not be, and will last a long time, much more stressed, much more depressed, than feeling that there were some things they could do, finding what the things were and kind of managing it in a more positive way. And of course, if you're disagreeing about your illness perception, if you as a carer just think that the illness is like this, and the service user thinks, no, there's nothing to worry about, of course that's going to make things more difficult. And of course, that's often the case. More recently, fortunately, people have started to look at positive caregiver experiences. George Smukler was one of the ones to start this. And it is interesting when you ask, many carers do talk about positives in the caring role, things they wouldn't have realised, feelings of satisfaction in improved self-esteem and their ability to manage all sorts of terrible things that they never thought they'd have to deal with. And this is related to feeling positive about yourself and what you're doing and your service user and how they're managing, and it's a good predictor of good outcome, particularly in some ethnic minority families. That seems to be one of the key things. And there's a very recent bit of research, I was just examining it in Denmark, that if you're able to stand back a little bit and self-reflect, it's quite complicated, this concept, metacognitive capacity, who knows what that means? If you're able to stand back a little bit and self-reflect about your caring role and how it's going, that also helps you to manage it more positively, rather than being so tied up with day-to-day managing and sort of just trying to firefight all the time. Trying to kind of step back and think about it a little bit differently, that can be really helpful. And when we've looked at coping, of course, it's the opposite of the avoidant coping. That seems to be the main thing that comes out every time. Seeking for yourself help and support, finding places to get help and support. It doesn't always matter where that is, and that's where the triangle of care is coming in, isn't it? They're trying to get services to help you and find places where you're getting the sort of support you need. And that's one of the things you're trying to do in family interventions, is trying to get people to stop the avoidant coping and actually manage things together in a much more positive way. No? Won't do it? It does it by itself when it wants to, yes. And the other thing we found, and that's a little bit more recent, there was a big survey in Italy, Magliano, that because we know that these serious mental illnesses still have a lot of stigma and shame and embarrassment, that you as a carer might have a reduced network yourself. And sometimes that's because people won't talk to you about it. People talk about their other family members not wanting to help, but it's a double bind, isn't it? And trying to make sure that you do have social contact, social support, that you normalise it in that way. And what we've called having a confidant, it's having someone who you can really talk to about how you feel. It's not very surprising, but it's actually really, really helpful to find that somewhere in the system. Now, it may be services and it may not. And it's related to significantly more positive caregiving experiences, even at first episode. There we go. So one of the points about looking at relationships is, how does it work? And this is where I was just going to talk about the models for a little bit. What is it that's kind of getting in? Why does it matter how you talk to someone, what's going on in family relationships? And one of the things that's very clear is that particularly negative relationships, they are perceived accurately by people with these problems. And it's often been thought that people with psychosis don't have very good social perception, don't really pick up in the same way on what's going on in the environment, and don't really understand in the same way, don't have such good theory of mind. But they pick up criticism and intense relationships really quite well. And so that was kind of a model of what does it do to you? If you've got a very difficult family relationship or you're finding it difficult when you go home, why is it upsetting? Why is it leading to further problems? And what we've thought and what we've probably shown is that it makes you more anxious and depressed to be told off, which again isn't really so very surprising, but it affects your mood. And this is just someone talking about it, a personal account, someone from one of our studies. And the most likely thing to trigger my paranoia is a comment or question that could have more than one meaning. And at least that's how it seems at the time. So this person is putting meaning on something that may not have been meant negatively at all. So there is that as well. It can be a comment that feels critical and I dwell on afterwards, so he's ruminating, and these comments are usually from people I know well, and of course he's got a reduced social network, so that's going to be his family. So the importance of having relationships where this isn't happening is really a good thing to hang on to. This is Broach Schizophrene from the, I think it's the Bethlehem Maudsley Archives, isn't it? Someone talking, and again, Patrick and his son were talking very clearly about the kind of problem someone is dealing with. They're not going to be very concerned about how you're feeling some of the time. People have got all sorts of things going on inside, all sorts of their own worries. They're not always in a good state to foster good relationships themselves. So what we thought of from our various models, if you look at what's happening in psychosis, how is it that difficult relationships or good relationships are going to make a difference? And we think it's because of mood. And we started to show that in some of the research, that if you've got a negative relationships like that, you don't feel very good. Nobody feels good. Marvellous. And the person themselves has more positive symptoms, has more delusions and hallucinations. And if you looked at healthy women compared to people who'd had depression, there was, if they had negative comments spoken, it affected the emotional part of their brain more quickly. So it upsets you. It's not very complicated. It just does. And I quite like this bit of research, I'm afraid. It was something that they did in America. And it's the effects of arguments. So again, this is kind of, how to have good relationships, whoever you are. And they had 42 normal married couples. And there's new evidence about how long it can take you to heal. How long you're, if you have a cut or what they did here was to burn you very slightly. And you can track very closely how long the skin takes to heal, how long that inflammatory response takes to go down. So they made half of these couples randomly have a row, and then they had a little burn. This was in America, ethical, don't nothing to do with me. had a little burn. Half of them had a row, and then they tracked how long it took to heal. And it takes longer to heal if you've had a bad row. There you are. Isn't that interesting? And it's just another kind of very physical thing about, bad relationships aren't good for anybody. This is just people who are walking about. It has nothing to do with psychosis. So, we all need to have good relationships. Good. What does that mean for treatments? We've tried to look directly at trying to help people themselves manage difficult relationships, because you can't always do family meetings, you can't always get carers involved, or the service users themselves won't let their carers be involved. And we did a little bit of work just looking to see if we could reframe how the service user felt about a really difficult relationship, i.e. by understanding where that comes from, that it's to do with care and concern, and that a difficult relationship isn't just one way, that they could contribute to that. And that's partly trying to reduce the impact of a negative relationship. So you might be able to do that independently of a family meeting and just with the person themselves, and that might be something to try. But all this research has led directly to the kind of work that's moved into family interventions, and I know it's not very available, but it's the important thing that it's being talked about. It didn't exist at all before the late 1980s, really. It didn't even exist. So this is about how to help improve outcomes for these very difficult conditions, both for people with psychosis and their carers. So there's lots of groups who've done this now. It's good evidence. And as I said, I was involved in these NICE guidelines. So there's been good published evidence from what are called randomized trials. So people do really quite hard tests to find out if things you do make a difference. There have been quite a lot of trials. And if you are lucky enough to have family interventions, then the risk of relapse is reduced, that you have better recovery. There's another review, someone called Cochrane does a lot of reviews. This is another independent group. They say family intervention may reduce relapse and readmission. This is with nearly 3,000 people, improve social impairment and reduce poor relationships. So it actually helps people be doing more, having more socially active roles in the family and outside. It's actually a very well-evidenced psychological treatment. And this is America. They have another guideline group called the PORT group in America. I'm not sure what it stands for. And again, they recommend family intervention and CBT, the cognitive behavioral work, for persistent symptoms because they work. And what we did in the latest guidelines, we only updated we updated the kind of team things. We didn't update the individual therapies. So that recommendation is still there, that you should have an offer of family intervention, and it should be about between 3 to 12 months 3 to 12 months long, and more than 10 sessions, not just a quick intervention. And what I quite like is that this time we were able to focus on carers' needs, and that's taken a long time to get anywhere near the front of anybody's agenda, as has been discussed, as May's discussed. And what we have wanted is that carers themselves are offered assessments of needs, and a formal social services one if that's necessary, that people should be given information. Good heavens, given information, really? And that there should be some negotiation between carers and service users about confidentiality, which is, of course, one of the reasons people won't let their carers be involved, and sharing appropriate risk information. Now, you don't need to know everything, but you do need to know about risk, and that you should keep reviewing it. If the service user says, no, I don't want my family involved, leave me alone, you keep reviewing that. You don't just accept that as a one-off. And trying to include carers in decision-making. This is obviously the triangle of care. Paul Bowington and I wrote a book in 1990 called Working in Partnership. I mean, this is a long time ago. It's 24 years ago, isn't it? Trying to get services to take take a triangulated look at what was going on rather than just be focusing on the service user. And very importantly, offering carers a focused education and support programme, which may be part of family intervention or may not. And I've been quite interested in offering this separately, because you can't always do family work, particularly with some of our very disorganised families in central London. And having a positive message about some sort of recovery, that this isn't just a problem that you can do nothing about. So, as you can see, I've been arguing this for years. Families should be seen as a positive and irreplaceable resource. They have needs of their own. I tried to get that. I did get it into the National Service Framework, I think that was. They have needs for care on their own behalf. It doesn't necessarily do any good to argue, but one does keep trying. McFarlane and Cook have had a rather fiercer view. Family members are as much victims of severe mental disorders as patients themselves. I'm not sure I'd quite say that, but it's pointing out that it's not just the service user, and that there's been a long history of all this research into it, and few interventions directly targeting carer distress. This is the Schizophrenia Commission again, the abandoned illness. I gave some evidence to this. They save the public purse, they're not receiving support and not treated as partners, and that was being said by the Royal College again in 2014. I hadn't seen that. But it is the case that carer outcomes can improve if anyone bothers to offer them support directly, as it sounds entirely as if Cause is doing. There's a review of 60 studies which showed positives for some carer outcomes, and there's been a first episode intervention program called REACT, trying to catch people right at the beginning. And there's something very important about trying to catch people right at the beginning before they kind of get set and before they're really shot into what on earth's going on and nobody's telling me anything and I don't know what to do. If you can catch people early, that's probably really quite helpful. Udojuku is someone from the NICE guidelines. We've just got that in press, and she did a meta-analysis that psychoeducation information and support is directly helpful for carers on their own anyway. And that this is one of the first times that this has been looked at. This is just a model of looking directly at carers and what you might do with them, which was published in the British Journal of Psychiatry, trying to understand some of the affective and cognitive reactions that you might have to the situation you find yourself in. So you don't need to look at this in detail, but it was more to make sure that people do focus on carers themselves. Because what does it mean for service provision? And as we know, services are very patchy. You do get good services, but it just really depends where you live. I think I'd have psychosis in Norway myself. They're quite good. Stavanger is quite a good place, but you can't organise that, can you? And it requires attention to the whole system. So I quite like the early intervention pattern in the UK, which again has had reasonably good evidence just recently, and I'm not sure if you do have early intervention services here or not, but the reason that they do well is because they try and offer a very integrated service, and they've been being cut and all the rest of it, but they try and offer individual CBT, individual work for the service user. They try and offer help to the family directly right at the beginning. They try and offer help with work and peer support and education opportunities. They try and have quite a holistic approach, evidence-based holistic approach to people at that stage, and it's the reason that things go better then is because they're doing that. And we need to extend that to longer term care. And again, I've been arguing that for long term. You shouldn't get, just because you get psychosis at 40, you shouldn't get a worse service than if you got it at 18. So I think people need their own service, their own carer service. There's no money for this, but that they need their own support. And this is what you're doing here, isn't it? So that's very interesting. And services must aim at supporting recovery in the whole family. This was from the Danish PhD, which is exactly what you've been saying. This was a model from the States because one of the reasons people don't do family interventions is they think it's too complicated and too difficult, and you've got to go home out of hours, and there's two people, and it's quite scary. It's actually quite scary for professionals to do. When I do training for professionals, a lot of them are quite frightened of having more than one person in the room. You're used to doing work with one person, but if there's two or three, who knows what they might say? And one of the ways to sort of get over this is I don't think everybody needs all singing and all dancing. You need the support you need at that time. So do you just need to know what's going on and who the care worker is and who to call? Do you need more information than that? Do you need to kind of have a bit more input at that stage? And looking at distress as your outcome. And do you need a crisis meeting 4 or 5 because things have been really quite poor and you don't know what to do and you don't know where to start? And if you're still distressed at the end of all that, there would be relatively few families who would need much more integrated family intervention, which services would be much better able to provide. So I think that kind of triage is quite a helpful way for services to think about it. And you could even use carer depression as a marker. If people are not coping, then, or even a bit depressed and finding it very difficult, that would be a very good reason for offering all sorts of things, particularly the more focused, the more long-term interventions. And particularly, you should be offering something right immediately for carers themselves. You should be offering help with, we did a little pilot offering help with crisis planning, with insomnia and distress, and help with what they needed at that stage, rather than just having something that service user needed. And mental health care is a website we set up with charitable money, and which we've used to have information. There's some information on your tables about that. And we've tried to meet this need just at least by offering information and discussion about the latest research and kind of what that means you might do. So I recommend that to you. And these are my colleagues. Nobody ever does anything by themselves. There's a great team behind you. And these are my colleagues who've worked in the Psychosis Research Partnership, including my husband who's sitting over there, who's contributed to these research findings. Thank you very much.